It is week 2 of your internal medicine residency as an intern. 1 week has gone by and you've learned so much already. So it's Monday morning, you come to work, your senior resident calls you and gives you your first admission. And the case goes like this. A 65-year-old male with a past medical history of hypertension, diabetes, hyperlipidemia, coronary artery disease with one stent placed 10 years ago, presents with complaint of chest pain. He describes the chest pain as pressure-like in the left side of his chest with radiation to the left shoulder. It was associated with palpitations and shortness of breath. The patient was cooking lunch when the pain started. He took his sublingual nitroglycerine, but the pain did not improve. So he called EMS and came to the hospital. Alright guys, so based on the history that's presented to you today, what do you think is going on? The patient is coming to you clearly with chest pain. So the big question for you is this chest pain really cardiac or not? That's your big question. So when you think about it, what makes a chest pain cardiac? Well, let me put it this way. In history, oftentimes patients are gonna have risk factors for the chest pain, right? So for instance, this patient has hyperlipidemia, he's got hypertension, diabetes, coronary artery disease in the past with the stent placement. Now these things in the history is very suggestive that yes, this may in fact be a cardiac chest pain. Now when you come to the chest pain itself, by nature, oftentimes people are going to tell you, oh, whenever I walk I get a chest pain. Now this chest pain is normally relieved on rest or nitroglycerin. That is the classic history of chronic stable angina. However, the chest pain, the way they should describe to you always is going to be the patient's got a retrosternal pressure like an elephant sitting on your chest, right? That's what they always taught us. And apart from that, you will have a radiation to the left shoulder or the left jaw. Also, what they would say is the chest pain is associated with certain other symptoms such as shortness of breath, right? Palpitation, excessive sweating, perspiration, right? All of these features are a sensation of impending doom. When they give you this classic history, of course you're gonna know, alright, this is most likely cardiac. Now the important thing is, the patient is coming to you with chest pain right now. So again, you know how to find out if it is a typical cardiac chest pain or not. So what makes it a non-cardiac chest pain? A non-cardiac chest pain is not the interest of subject for our lecture today. However, we'll just go over a couple of points which will tell you, okay, this is not cardiac. So the important things what you should know is if they tell you, oh, I had a fever for the past 1 week, or they have, whenever they take a deep breath, they feel chest pain, right? This is known as the pleuritic chest pain. Or for instance, the patient got some form of early viral illness in the past 1 to 2 weeks, and now the patient's coming to you with again chest pain. Again, the chest pain varies with the patient's position. You're thinking of pericarditis. The other thing they can tell you is, oh, I'm coming with some form of chest tenderness, right? And then they tell you, oh, whenever I touch the ribs right here, I feel pain, right? Whenever you can reproduce a chest pain, that is most likely not cardiac, it's musculoskeletal, right? So this is basically going to be very typical of costochondritis, also known as Tietze syndrome. Alright guys, so these are just a few important tricks and points that you must remember to rule out a non-cardiac cause, and let's focus on this patient who's coming to you right now with a cardiac chest pain. So based on the history that's presented to you, clearly you know that this patient is most likely having a cardiac chest pain. So let's go right into the physical examination. So on physical exam, the patient has a vital sign, blood pressure 150/90, heart rate of 80, respiratory rate of 16, and a temperature of 99 degree Fahrenheit. And in general examination, the guy is holding his chest and saying, I have chest pain. All right, so the guy is an active chest pain right now. That's an important finding. All right, apart from that, if you go to the head, eyes, ear, nose, and throat, it is normal. You don't find any form of abnormalities. Cardiovascular, S1, S2 heard, no rubs, no gallops, no murmurs, not even an S3, everything sounds normal. Alright, respiratory system, patient's got normal clear lung sounds bilaterally, no bibasilar crackles, no wheezing, nothing's going on. Alright, abdominal exam is also normal, there's nothing to be found. So this is exactly how your patient is present most of the time. Alright, patient will have chest pain, but you're not going to really have much of physical findings suggestive of anything. However, does it rule out a lot of things? Yes, it does. If the patient did have a reproducible chest pain right here in the second costochondral region, you're going to think of a TC syndrome, which is known as costochondritis. All right, but if you do certain maneuvers and the patient has decreased chest pain or worsening of chest pain, then you're thinking more of pericarditis or pleuritis, which none of them is going to be present with your patient who's actually coming to you with a cardiac chest pain. All right guys, so based on physical exam, you have already framed your working diagnosis. So let's dive right into your labs and orders. So based on the history and physical exam so far, we know that this patient is most likely having a cardiac chest pain. Now when you come into a cardiac chest pain, what is your working diagnosis at this point? You are going to call this a acute coronary syndrome, right? Acute coronary syndrome. And an acute coronary syndrome composed of three different parts, going from the mildest form to the most severe form. The mildest form that you are expected to know is unstable angina. All right, and the next part is gonna be called a non-ST elevation MI, non-STEMI. And lastly, which is the worst one, is going to be called a STEMI. So the big question really on your EKG, what you're trying to ask is, does the patient have ST segment elevation suggestive of ST elevation MI or not? So this is patient, you do the EKG and the patient does not have any form of ST segment elevation. All right, so you ruled out the presence of a STEMI. All right, great. But now your question is, what does the patient have? Is it a non-STEMI or unstable angina? So what would you see in a patient's EKG with either one of these two? Well, the thing is this. Here, you could either see just random ST segment changes such as ST segment depressions, or you could see T-wave inversions, or the EKG could be completely fine, right? So these are the findings you're going to have with unstable angina and non-STEMI. So how are you going to differentiate? Oh, is this unstable angina or is this non-STEMI? Are you saying that if you have an MI, you will have leakage of troponin? You're absolutely correct. So if a patient is going to be called myocardial infarction, you must have elevated troponin. That is it. If you have an elevated troponin, you will call it a non-ST elevation MI. So the moment you have an MI, you must have elevated troponin. So unstable angina, you will have chest pain. You may or may not have EKG changes. Would you have troponin? Absolutely not. You will not have troponins in unstable angina. If you look at non-STEMI, patient's going to come with chest pain. EKG may or may not have changes, but will the patient have troponin? Yes, the patient will have troponin. And if the patient is coming with the ST elevation MI, will the patient be in chest pain? Yes, the patient is going to have chest pain. Will the patient have an ST segment elevation seen in the EKG? Yes, there will be ST segment elevation. And will the patient have elevated troponin? Absolutely yes. So now I hope you guys got the idea. Now here in this patient, we are talking about a patient who has most likely unstable angina or non-STEMI, because I already told you the patient did not have ST elevations. So fine, your basic test that you're going to order is a troponin. And how often are you going to do your troponin? You are going to do your troponin every 8 hourly. So Q8 hourly, you're going to do troponin levels. What other lab tests are you going to order on this patient? You're going to get a BNP, okay? You're going to get a BNP level to see if the cardiac function is okay or not. You're also going to get a CBC. You're getting a CBC because you want to see the patient's hemoglobin, you want to see what the patient's platelet counts are, because you are going to essentially treat patients with unstable angina and non-STEMI with certain medication that's going to cause bleeding, all right? So you want to know the baseline of these two things and see if there's any contraindication for you to actually start treatment. Then you also want to know your PTT, PT, INR. Again, it's the sole reason you're getting these tests is because your treatment is going to be affecting these numbers. And then a lipid panel, right? You want to get a lipid panel on this patient. Chest x-ray, again, if you want to, you can get it, because if you're thinking of something else, you want to rule them out, you can get a baseline chest x-ray as well. All right guys, so we're done with the labs and orders. So now let's go to the most important part, which is going to be your assessment and plan. All right guys, so now we have a working diagnosis of unstable angina or non-STEMI. A lot of people used to ask me all the time saying, oh, is it unstable angina? Is it non-STEMI? It's important for you to know what the definition is. However, does the treatment change? It actually doesn't. The treatment does not change. If it's unstable angina or a non-ST elevation MI, the treatment is exactly the same. So let's see what are the components of the treatment. So these are the two most important things you must tell me. If I ask you what's the treatment for unstable angina or non-STEMI, you must tell me I'm going to treat the patient with dual antiplatelet therapy and full dose anticoagulation. So let's repeat this. You are going to give the patient dual antiplatelet therapy and full dose anticoagulation. Those are your two big components of treatment of unstable angina or non-STEMI. So let's talk about the dual antiplatelet therapy. Now what you're going to do is you are obviously going to use aspirin, which is your first medication you're going to use, and then you are going to choose your P2Y12 inhibitors. Your P2Y12 inhibitors, basically your ADP receptor blockers. You have a few of them. So you have clopidogrel, you have your ticagrelor, and then you also have prasugrel, and you also have another one called cangrelor. Now the first generation P2Y12 inhibitor is actually clopidogrel, and then your newer generation ones are ticagrelor and prasugrel. However, prasugrel and cangrelor, we don't use it so much. Okay, so I'm just going to focus on the important dosings of the more commonly used ones. Now aspirin, when the patient comes, so clearly you're going to give dual antiplatelet therapy. Okay, what's your loading dose? You must always do loading dose of both these medications, and you'll continue a daily dose. So you must know your loading dosing of these medication and your daily dosing. So aspirin, your loading dose is going to be 325 milligrams is your loading dose, and you're going to give daily 81 milligrams. All right, so you're going to do daily 81 milligrams, but your loading dose is going to be 325 milligrams. Your clopidogrel, what is your loading dose? Are you saying 300? You're absolutely correct. So your loading dose for clopidogrel is going to be 300 milligrams, and your daily dose of clopidogrel is going to be 75 milligrams. What about ticagrelor? Now ticagrelor is the only one you're actually going to use in a BID fashion. The dosing for ticagrelor loading is going to be 180 milligrams, and your daily dose is going to be 90 milligrams. Alright, now prasugrel and cangrelor again we don't use it so much at all. Prasugrel, important contraindications you must know. The most important absolute contraindication for prasugrel usage is a patient with a previous TIA or stroke. And relative contraindications that are present for prasugrel is a patient age above 70 or a patient's got a low weight. So these are the important factors that is taken into the choice of using prasugrel or not. So again, these two we don't use it so much, so I'm going to stick to your aspirin, clopidogrel and ticagrelor. So you must know you are going to give your patient dual antiplatelet therapy. So after your dual antiplatelet therapy, obviously your next medication you're going to tell me is your full dose anticoagulation. So again, there are multiple different choices that you could use, but the most common ones we are often going to use in the hospital is your low molecular weight heparin, which is known as Lovenox, or you're going to use your heparin. Now these are your two main options that I want you guys to remember. You're going to have Lovenox or heparin. Now the choice of which one you're going to use is really dependent upon a few things. If you have a patient who's going to go for an angiography, alright, if you're going to go for an angiography within the next 48 hours, you prefer to do heparin. Reason is heparin has a much shorter half-life, and therefore you can control it much better. So that's one important reason. And the other reason again is, if you recall from the previous lecture, you should know that heparin is preferred if a patient has got a high creatinine, right? If the patient has got increased creatinine, essentially saying the patient has got chronic kidney disease. Alright, so if the GFR is low, again heparin is preferred. Now how do you calculate what the loading, the optimal dosing for these two medications are? We call it full dose anticoagulation. So Lovenox, your full dose anticoagulation could be two things. It could be 1 milligram per kilogram of body weight, BID, or you could do 1.5 milligram per kilogram of body weight once daily. It's pretty straightforward. It's very easy. You do 1 milligram per kilogram BID, or you do 1.5 milligram per kilogram once daily. That's it. For Lovenox, it's very straightforward. Heparin, on the other hand, you must do a loading bolus, and then you're going to continue a drip, and you're going to target a PTT. So we'll come to each step. Heparin loading dose, you could do between 50 to 70 units per kilogram of body weight as your loading dose. So you can do 50 to 70 units per kilogram of body weight as your loading dose, and after that you could do 12 units per kilogram of body weight of the heparin drip, and again now you're going to target a certain PTT. So how do you calculate what your PTT target is, right? It's an important question. You must know the answer to this. The important and the best answer to this is in fact going to be 1.5 or 1.5 to 2.5 of the patient's baseline PTT. So whatever the patient's baseline PTT is, you're going to do 1.5 to 2.5 times of the patient's baseline. That's it. That's pretty straightforward. A lot of people say a rule of thumb you can do between 50 to 75. Yes, you can. However, to be accurate, you go 1.5 to 2.5 times the patient's baseline. So just to recap, guys, if you have a patient who's coming with unstable angina or non-STEMI, what is your treatment? Dual antiplatelet therapy and full dose anticoagulation. You already know how to choose them. All right, aspirin always comes into play, and you combine it with a second medication, which is going to be your P2Y12 inhibitors. So you do a loading dose and continue a daily dose of dual antiplatelet therapy and full dose anticoagulation. You're done with your most important component. However, you cannot forget the rest of the players in this treatment. So the rest of the players you must know is obviously your statin. If you guys can recall, what is the high intensity statin that you guys know of? Because if you are having an acute coronary syndrome, you must treat the patient with a high intensity statin. There's only two high intensity statins. One is atorvastatin, the other one is rosuvastatin. Atorvastatin, the high intensity dosing is in fact going to be 40 milligrams to 80 milligrams HS at bedtime is when you give it, and rosuvastatin, it's 20 milligrams to 40 milligrams HS, again bedtime. Now atorvastatin and rosuvastatin, high intensity statin, you can actually start off with the highest dose possible because it's good. You want that anti-inflammatory effect of the statins, right? So you want to start them on high intensity statin at the same time. Alright, next question is beta blockers. Now again, we have already gone through your heart failure, and I told you there was only 3 beta blockers that actually had mortality benefit. What about coronary artery disease? Which beta blockers are going to have mortality benefit? The cool thing is, in coronary artery disease, all beta blockers have a mortality benefit. So your choice is endless. You can choose any beta blocker you want. Alright, sometimes they do say the cardio selective ones are actually preferred, but still all beta blockers do have mortality benefit in the context of coronary artery disease. But will you start a patient on beta blocker? Yes, within 24 hours of presentation you must start the patient on a beta blocker because it does have mortality benefit. Alright, next component is oxygen. Do you have to give oxygen to every patient who comes with chest pain? Please tell me no. Alright, very good. The reason is, if the patient is hypoxic for whatever reason, because of the acute MI, maybe the patient is in heart failure now. Those patients who have a pulse ox saturation less than 90, you can give them oxygen. Of course, fine, because the guy is hypoxic. But if the patient is saturating at 100% on room air, why give this guy oxygen? There's no reason to. Alright, so your choice of oxygen comes in only if the patient is gonna be hypoxic. Alright, if not, do not use oxygen. What about pain medication? Now morphine, everybody likes to use morphine. Yes, for the longest time we have been giving morphine to patients with acute coronary syndrome, and we still can do it, but only if the patient is having very severe pain. All right, only if the patient has got a very severe pain will you use morphine, because if the patient's got a very mild pain to moderate pain, you don't have to use morphine, because morphine actually has some negative outcomes in patient with coronary artery disease. So you could use morphine, but try to avoid it if the patient is in mild to moderate pain. Finally, nitroglycerine. Now this is a big one, right? Important thing is nitroglycerine, as you guys already know, right? It's basically going to cause what? It's going to cause venodilation and decrease preload and decrease the stress on the heart, right? So nitroglycerine is the big drug that we normally give as 0.4 milligrams right, as sublingual capsules or sublingual tablet that you're going to put it under the tongue. It's going to dissolve and cause instant relief of chest pain as well as improve the patient's symptoms, right? So nitroglycerin. So the next important question for you really is, how many times can you give the patient nitroglycerin? You can give up to 3 tablets, okay? After the patient received 3 tablets of nitroglycerin, and if the patient's symptoms does not improve, what are you going to do next, right? At that point, after 3 tablets, if it does not improve, you will go on to a nitroglycerin drip. All right, this is an important point to remember. So nitroglycerin drip after 3 tablets if the symptoms do not improve. So this completes our major part of the management of your patient with unstable angina or non-STEMI, right? You have dual antiplatelets, full dose anticoagulation, you got your high intensity statin, you have your beta blockers, you know your oxygen pain medications and nitroglycerin. Alright, I know USMLE loves to ask us a question about our GP2B3A inhibitors, the specific medications of GP2B3A inhibitors, right? Medications such as apixaban, right? You have tirofiban, you have eptifibatide. Are we going to use these medications as an intern? Do you need to know how to use this medication? I don't really think so. I just want you to know that you can remember these drugs as a medication that is used in the context of coronary artery disease, but they will be used in the cardiac cath lab when they are doing angiography. That's all you need to remember from an intern perspective. All right, all you need to know, these medications you will see being used by cardiologists during the coronary angiographic procedure. Now up to about 10 hours after that they could still use it, but it will be used by them. So I just want to remember those medications, but don't make it a big deal out of it. All right, I think as an intern you've already managed your patient perfectly well. However, does it end here? I don't think so, right? Because the guy is still coming with chest pain. You're treating him for an unstable angina and non-STEMI. You did all your medications. Now the patient is chest pain free and he's there in the hospital. Now what do we want to do next? That's the question, right? Important thing is, where does the patient go from here, right? So important decision that you have to make is, because either way you need to actually prove if this patient has a coronary artery disease or not, right? So how are you going to decide what test you're going to do? Is it going to be a stress test, or is it going to be a dobutamine echo? Is it going to be a nuclear stress test, or are you going to go directly to an angiography? That's your big question. So your question really is, all right, is this guy sick enough that you are going to go directly to angiography, or is the patient going to go for some form of non-invasive stress test, right? That's your big question. Now you can have a decision making just based on looking at all these things, or you could have a very objective method to find out if what test you're gonna do, right? That's awesome. We can use the TIMI score. TIMI stands for thrombolysis in myocardial infarction. So you must do what your TIMI score is. So TIMI score goes like this. If a patient has age more than 65, then the patient is going to get 1 point. If you have more than 3 risk factors for coronary artery disease, risk factors you guys should already know about, which is hypertension, diabetes, hyperlipidemia, family history of coronary artery disease, right? These are your risk factors. So you need 3 or more risk factors for coronary artery disease. Prior stenosis more than 50%. For instance, a patient has a previous stent placement. Remember, you'll only put stents in if the patient has more than 70% occlusion most of the time, right? So if this patient had a stent put in the past, which means he definitely has more than 50% stenosis. All right, so that's another one. Number 4, if the patient is on aspirin in the past 1 week. Number 5, if the patient has more than 1 anginal episodes in the past 24 hours, essentially meaning 2 or more anginal episodes in the past 24 hours. Then you can have ST segment changes, not ST elevation, but ST segment depression, maybe a T wave changes. Again, the ST segment, if you have some changes, it also gets a point. And lastly, number 7 is elevated cardiac enzyme, which is going to be your troponin. All right, so it's 7 points, right? So the way you're going to see it is this. It's very, very straightforward. If you have 0 to 2, you will call this low risk. If it is 3 to 4, it's intermediate risk. If it is 5 to 7, it's high risk. What you're going to do is, I want you to separate it out from here. That's it. If it's low risk, you can go for a non-invasive stress test. All right, non-invasive stress test if it's low risk. Whereas if the patient has intermediate to high risk, essentially meaning if the patient has a TIMI score greater than 3, this patient ideally should go for a coronary angiography. Straight up, he should go for a cardiac cath. So the patient must go for a coronary angiography. All right, if the patient has intermediate to high risk, straight up the patient must go for a coronary angiography. Based on the coronary angiography, you will decide if the patient requires a stent placement or not. That's it. It's pretty straightforward. So now you guys already know how you're going to manage a patient with unstable angina and non-STEMI. That's it. You have to treat them. However, you must also know what kind of ischemic workup you are going to do. So you're done with the treatment of your patient and you chose what kind of ischemic workup you're going to do for this patient. So now you've come to the point where you're going to actually discharge this patient home, right? Now, one important question that I'm going to ask you is, for instance, this patient who came with an unstable angina or a non-STEMI undergoes a cardiac catheterization and he has some stenosis but does not get a stent. So no stent. Are you going to continue this patient on dual antiplatelet therapy? Yes, you are. And how long are you going to continue dual antiplatelet therapy on this patient? At least for 1 year. At least for 1 year. So my point I'm trying to make is, if the patient comes to you with an unstable angina, non-STEMI, acute coronary syndrome, if the patient comes to you and still does not get a stent, he still has to be on dual antiplatelet therapy for at least 1 year. So you guys must know this. Now the same patient, if the patient did get a stent, what is the patient going to be on? Again, dual antiplatelets for 1 year. So my point I'm trying to make is, whether the patient gets a stent or not, acute coronary syndrome by itself will require dual antiplatelet therapy for at least 1 year. All right, and in addition to that, obviously you're going to discharge the patient on a statin. The patient is going to also go home on a beta blocker. All right guys, I hope you guys really enjoyed this lecture, because this is the big one. You are going to see a ton of cases who are going to come with unstable angina as well as non-STEMI, but you know everything already. You know exactly how to manage, you know exactly what test you're going to do, and you're not going to make a simple decision based on whatever you feel like. You're going to actually objectively decide what kind of ischemic workup you're going to do. So that's it guys. This brings us to the end of our chapter on unstable angina and non-STEMI. Alright guys, so I'll see you guys on the next video.